Every year, more than 100,000 people are diagnosed with leptomeningeal cancer, and yet we do not have the tools to prevent, diagnose, or treat this disease. The Leptomeningeal Cancer Foundation is here to change that. Working with medical experts, researchers, patients, and their families, we will raise awareness, educate patients and healthcare providers, and support research. Please visit us at lmcancer.org and follow us on social media. We are here to support you and ensure that you never feel alone. Hi, everyone. Welcome to today's webinar. We are so grateful that you are taking the time out of your day to join us. I'm Helene Bader. I'm the founder and president of the Leptomeningeal Cancer Foundation. And as many of you know, I started this foundation in honor of my son, Theo, who died at the age of 17 from leptomeningeal cancer. And I'm now here hoping to help others navigate this disease, find the information they need, and support the advancement of research and new treatments. And all the while honoring Theo, the other amazing people we've lost from this disease, and all of you here who are living with or caring for someone with leptomeningeal cancer. So thank you for joining us when I know it's not always an easy task. Before we jump into the introductions and presentation, just a few things. We do have live captioning available, so please use the closed caption icon box to turn on captioning or click the View Full Transcript under the Captions and Translation panel. Please use the Q&A function for your questions. You can enter them as they arise, and we will get to as many as possible. If you sent one in during registration, I have those ready to ask as well, and we'll ask them at the end of the presentations. Please know that our presenting doctors cannot provide medical advice on the webinar, so if we can get any questions that are specific to a personal situation, we won't be able to answer those. And on that same note, just a reminder that the information you hear today is not intended as medical advice or as a substitute for medical care. So please speak with your own doctor about any healthcare decisions and your personal care plan. Thank you for understanding. So today we are focusing on breast cancer and leptomeningeal spread, and we have two incredible experts with us. First, we have Dr. Nancy Lin. Dr. Lin serves as Associate Chief of the Division of Breast Oncology at Dana-Farber. She is the founder and director of the Metastatic Breast Cancer Program and the Program for Patients with Breast Cancer Brain Metastases. She is internationally recognized for her expertise in the care of patients with all stages of breast cancer. A professor of medicine at Harvard Medical School, Dr. Lin's research focuses on developing more effective therapies for patients with metastatic breast cancer, including patients with brain metastases or leptomeningeal disease. She has led multiple clinical trials that have led to new treatment options for patients with metastatic breast cancer. Dr. Lin is also an active translational science researcher and directs the breast oncology cohorts and biorepository program at Dana-Farber. Welcome, Dr. Lin. Next, we have Dr. Priya Kumtekar. Dr. Kumtekar is professor of neurology and hematology oncology at Northwestern University. She is a United Council of Neurologic Subspecialties board-certified neuro-oncologist who is very involved in leading and designing clinical trials in neuro-oncology, especially in the challenging space of glioblastoma and CNS metastases. She has an established track record of completed clinical trials and has served as a principal investigator of over half a dozen multi-center trials and as site principal investigator for almost a dozen other studies. Dr. Kumtekar has teamed with basic scientists at Northwestern and other institutions to translate bench research to advance the field of neuro-oncology. She serves as co-chair of the Scientific Review Committee for the Robert H. Lurie Comprehensive Cancer Center at Northwestern University. Welcome, Dr. Kumtekar. And now I'll turn it over to Dr. Lin to begin the presentation.
Thank you so much. I'm really delighted and honored to be here today. And I do want to just really give a particular shout out to Helene, who, this is such a labor of love. And I know that it's so meaningful both to her and to all of you. So my job today is really to give first an overview of how we treat people with metastatic breast cancer, and then you'll hear more detail about specific treatments for leptomeningeal disease when Dr. Kumtekar takes on the discussion. So without further ado, we'll get into the content. So if we think about breast cancer, really more and more, we really think about breast cancer in different breast cancer subtypes, and there are three major subtypes. Some would argue four major subtypes. They include estrogen receptor positive or hormone positive breast cancer. These are breast cancers that are positive for estrogen receptor and negative for a marker called HER2. And that negative includes both HER2 low and HER2 ultra low breast cancer, if you've heard of those terms. HER2 positive breast cancer are cancers that are positive for the HER2 marker, and they can be either triple positive, meaning estrogen positive, HER2 positive, or they can just be HER2 positive, meaning ER negative or estrogen receptor negative and HER2 positive. And finally is triple negative breast cancer. We call it that because it's negative for three markers, estrogen, progesterone, and HER2. If you're not sure what type of breast cancer you have, this is a really good question to ask your doctor because a lot of the treatments that we give really based on subtype. So first, what testing can or should be done? And I wanted to just introduce some terms here because I think it can be a little bit confusing. We can do something called germline testing or genetic testing, and this is generally done on blood or saliva. And the purpose here is to look for an inherited mutation. So mutations in genes that you might have inherited or been passed down from either your father or your mother's side of the family. And the three most important genes here to look at are BRCA1, BRCA2, and a gene called PALB2. And the reason that these are important is because mutations in these genes do allow the use of a medicine called a PARP inhibitor, which are effective oral pills that are really specific for these mutations. We can also do what's called receptor testing on the actual tumor itself, either from surgery or a biopsy. And we're looking at generally three major markers, estrogen, progesterone, and HER2. We can also test the tumor for other markers. So for patients with triple negative breast cancer, it's important to test for a marker called PD-L1, and that determines whether or not there would be benefit for immune-based approaches or approaches that stimulate the immune system. We can sequence the tumor, and we can do this either on a biopsy or surgical specimen. We also can do this from the blood, and sometimes your doctors might refer to this as a blood biopsy or a liquid biopsy. So it's a little confusing because there's so many names that we use for the same thing. But here what we're looking for are mutations or changes in the cancer, not necessarily inherited mutations. And this is most important in people who have estrogen receptor positive breast cancer, but also can be helpful in other subtypes, including triple negative breast cancer. And here we're again looking for changes in the genes in the cancer. And then finally, there's other special testing. So sometimes clinical trials will require a special test to qualify, and that's going to depend on the trial. So first, what I'm going to do at this point, just to orient you, is to go through what is the treatment path for each of the three major types of breast cancer. And the way these slides are oriented is there's a box with the treatment, and under the box, there's a red box that gives the name of the clinical trial that led to that treatment or led to the FDA approval. I know that this webinar is being recorded, and so later, if you wanted to look online for the trial and get more information, that would be a good way to do this. So for people with ER-positive metastatic breast cancer, for most patients, we're going to start with hormonal therapy plus a CDK4/6 inhibitor. And the three CDK4/6 inhibitors that are currently approved by the FDA are abemaciclib, otherwise known as Verzenio, ribociclib, otherwise known as Kisqali, and palbociclib, otherwise known as Ibrance. This is the path for most patients. Rarely we will need to start with chemotherapy, but for the most part, over 90% of patients really can start with hormonal therapy. There has been a new FDA approval recently that takes a small proportion of patients and allows them to receive a three-drug regimen, which is the combination of fulvestrant, which is a hormonal therapy, and inavolisib, a new medicine that targets the PIK3CA pathway, the PI3 kinase pathway, and then another drug, which is the CDK inhibitor, palbociclib. This is really restricted to patients who have that specific mutation and who have particularly aggressive disease where the cancer comes back either while on hormonal therapy or within 12 months of finishing hormonal therapy for early stage disease. After the first line of treatment, if and when the cancer gets worse, there's a whole variety of treatments that are now available, and we can go from one to another depending on whether you respond to the treatment, where the cancer is located, and how quickly or not quickly the cancer is getting worse. And so there are many, many treatments. These are not listed in order of preference or priority. They're just showing the range of treatments. And what I want to point out from here is just that the importance of actually doing either a liquid biopsy, a sort of blood test, or a tissue biopsy to be able to understand the mutations, because that really does open up different treatment options. So just walking from left to right, One possibility would be to reuse the CDK inhibitor, so to use something like hormonal therapy with Faslodex or fulvestrant along with a CDK inhibitor called abemaciclib if that wasn't given as a first treatment. It's also possible to pair hormonal therapy with an oral medicine called everolimus, or occasionally, although much less so these days, we might give fulvestrant on its own. If the cancer has a mutation in the estrogen receptor gene, there are two drugs now approved by the FDA, elacestrant and imlunestrant, and these are possible to give as pills on their own. Occasionally, less than 5% of the time, but a little more common in lobular breast cancer, are mutations in the HER2 gene. And this is even in patients who have HER2 negative breast cancer. And that opens up combinations that include either neratinib or tucatinib. These are oral medicines that target HER2. And then finally, for patients whose cancers have mutations or changes in the genes PIK3CA, AKT, or PTEN, there is a relatively recent approval for a medicine called capivasertib, which we combine with hormonal therapy. Less so, we might combine it with alpelisib, but overall, I think the side effect profile with capivasertib is better than with alpelisib, so we've mostly switched to using capivasertib. But again, I think the point here is that there are many different options, and there are a number of additional options that will likely have decisions by the FDA sometime in the next 6 to 12 months. And so it's possible that in the relatively near future, we may have additional options, including camizestrant, giredestrant, gedatolisib, and vepdegestrant. And I know these are all tongue twisters, but I think the point is that there's a lot of options coming up. What about non-hormonal options? So when we get to the point where we need to switch to chemotherapy or non-hormonal therapy-based approaches, what do we have? The left box just shows the variety of chemotherapy drugs that still are effective and we do cycle through. In the middle are some of the more targeted treatments. So if a person has, it's HER2 negative disease, but there's a little bit of HER2 on the surface of the cell, we call that HER2 low. And for those patients can be eligible for a medicine called trastuzumab deruxtecan or Enhertu. And what's important about this is that this is a medicine that does have potential activity in patients with leptomeningeal disease. We also have the potential to give what's called a PARP inhibitor. So there are two commercially available PARP inhibitors. And again, we have seen some activity in the brain with these agents. If the tumor has a high tumor mutation burden, so the tumor is very mutated, we can give immunotherapy, and the immunotherapy is called pembrolizumab or Keytruda. For patients, irrespective of various markers on their tumor, it is possible to give a different type of targeted medicine, which is called sacituzumab govitecan. So that is a chemo attached to an antibody that finds its way to the cancer cell and allows targeting. And finally, a similar medicine called datopotamab deruxtecan or Datroway. So the key takeaways for estrogen receptor positive metastatic breast cancer are that there are an increasing number of treatment options. And as you can see, based on the algorithms for treatment, it's increasingly important that we have information about your genetic testing in terms of inherited mutations and about tumor testing as far as the tumor mutations. Now moving on to triple negative breast cancer, this is what the current map looks like. We currently give patients who have the marker PD-L1 positive chemotherapy along with immune therapy in the form of pembrolizumab. For patients whose tumor testing is PD-L1 negative, we generally start with chemotherapy. And for those who have an inherited mutation in BRCA1, BRCA2, or PALB2, we can start with a PARP inhibitor. However, this is likely going to change in the very near future because of data we saw really in the last week with phase 3 trials that demonstrated improvements over traditional chemotherapy with these so-called antibody drug conjugate drugs or ADCs. So as the first treatment for patients with triple negative breast cancer that's PD-L1 positive, it's very likely that in the near future we will be switching to the combination of Trodelvy with immunotherapy. And for patients who have PD-L1 negative cancers, again, very likely in the future, we will be switching our regimens to either Trodelvy or Datroway. I will say if you're already in one of the existing regimens with regular chemo and your cancer is behaving itself, it's responding, we would not switch you to these newer regimens until the cancer got worse. But for newly diagnosed patients, I think this is what we're going to be doing in the future. And then after the first treatment, what do we do? Well, we can use, again, these so-called antibody drug conjugate medicines. Those are shown on the left. We can use PARP inhibitors. We can use immunotherapy. If a patient does have this rare mutation in HER2, we can use HER2-directed treatment even in patients with HER2-negative breast cancer. And then we have a lot of chemotherapies that could be considered. So key takeaways for triple-negative breast cancer are, again, increasing number of treatment options and the importance of the tumor testing specifically for the inherited mutations, for PD-L1 status, and for HER2 low status, as these really significantly change the treatment options that are available. The final subtype of breast cancer is HER2 positive breast cancer. Again, this is the current way that we treat patients or sequence patients through time. Usually we start with Herceptin or trastuzumab with Perjeta, along with a Taxol or taxane type of chemotherapy. When the cancer gets worse, we move on, in most cases, to a medicine called Enhertu, but sometimes we might consider the combination of tucatinib, trastuzumab, and the oral chemo capecitabine. And as a third treatment, we often will flip around to whichever one patients didn't receive, or occasionally we might give a medicine called TDM1. One of the things that we've learned is, of course, things change, and that's a good thing, that there's a lot of progress that is happening very quickly. And so we did see data from a clinical trial called Patina that when we put people on maintenance trastuzumab pertuzumab after patients have their initial chemotherapy-containing regimen, that it actually is very helpful to add in both hormonal therapy and the medicine called palbociclib. And now we've further seen some additional changes because we saw a very important clinical trial called Destiny Breast 09 that showed if we swap in HER2 or trastuzumab deruxtecan as the first treatment, that we are seeing better tumor control that is of longer duration. And so one of the questions right now that oncologists are trying to sort out is, does everybody need to do the swap? Can some people just start with the Taxol, Herceptin, Perjeta from the get-go? And certainly for patients who are already on Taxol, Herceptin, Perjeta who are doing well, we're generally not swapping patients. We're leaving them on treatment that's effective. And then later on, there are lots of different options of combinations, often Herceptin with a variety of different chemotherapy regimens. So questions to ask your oncologist, important questions are, what subtype of breast cancer do you have? And is there any other testing that should be done? As you talk about the options, and especially when we think about options for leptomeningeal disease, what I focus on today are the systemic therapy and chemotherapy treatments that we give for metastatic breast cancer. But one of the important distinguishing factors when people have leptomeningeal disease is that there are radiation surgical options to consider, and you'll hear more about these from Dr. Kumtekar. There's also the question of whether there's a clinical trial option, and of course, a question that's always important is, why are you recommending this particular option for me? As you'll hear more about, when we treat patients who have cancer that's spread to the brain or the spinal fluid, it's really important that your doctors work together as a team with you. And so it's a good question. How do you work together as a team? What is the process to do this? And then for every treatment option, of course, what are the anticipated benefits and the side effects? I'll say a few words about clinical trials, which is that I think that clinical trials I think of as really not just the last resort. I encourage people to be open-minded about what type of trial it is. Sometimes people are very worried about phase 1 trials versus phase 2 or 3 trials, but really I would base the decision about how important or how much to prioritize a trial more based on what is the therapy being tested, what is the data what we have so far to say that it might be useful, what are the side effects and potential benefits, what's the schedule, how inconvenient is it? These are all good questions, but I would be sort of perhaps a little bit less prioritized in terms of, is it called a phase 1, 2, or 3 trial? Unfortunately, many trials still exclude patients who have either active brain metastases or leptomeningeal disease, but things are changing. And so I no longer assume that patients will be excluded, which is what I used to do. Now I'm looking very carefully at the wording of the eligibility in clinical trials because more and more we do see trials um, where it would be possible to enroll patients who have cancer that spread to the brain. And so if you're interested in clinical trials, definitely let your oncology team know. Let them know if you're willing to travel and how far you might be willing to travel. Consider a second opinion and explore clinical trial matching resources.
Great. I'll take it from there. Thanks so much, Nancy. I've always learned from Dr. Lynn's talk, and today's no different. So thank you so much for that. And I will take it from here again. I'm Priya Kumtekar. I'm a neuro-oncologist in the Chicago area. And I'm going to shift gears from this wonderful foundation that Dr. Lynn has laid and talk about specifically leptomeningeal disease in breast cancer. So just a little background for those of you who are not familiar. When we say leptomeningeal disease, what we are talking about is cancer cells in the fluid that surrounds the brain and spinal cord. And that fluid is, of course, called cerebrospinal fluid. So this is cancer geographically in the space of the pia and arachnoid matter for those medical folks, the layers of like saran wrap basically closest to the brain and covering it. This can happen in solid malignancy, so breast cancer, lung cancer, melanoma, as well as hematologic or liquid cancers like leukemia. And when we do see leptomeningeal disease, I think of the symptoms in sort of two different buckets. So that first bucket is symptoms that are related to increased pressure or intracranial pressure, increased pressure around the brain and spinal cord. So those are things like headache, lethargy, that sort of thing, more generalized. And then we can also see a lot of focal symptoms. So in that fluid space lives nerves that control the face and head structure. So those are called cranial nerves. And then down the spine, the spinal nerves come out from that fluid as well. So you can imagine if cancer cells accumulate or disrupt these nerves, we can get symptoms related to that. So cranial nerve symptoms can be things like double vision, blurry vision, hearing loss, chewing, swallowing issues, maybe facial weakness or numbness, etc. And then spinal nerve root issues can cause pain, so like radicular pain, so pain that moves to your arms and legs, as well as things like bowel or bladder symptoms. So early on, we might see things like constipation, and then that can escalate to even incontinence. So lots of different symptoms based on the geography of leptomeningeal disease. Lepto has in general been pretty difficult to treat, although I definitely want to add some flavors of hope today in my later slides where I talk about some of the changes that have happened, and Dr. Lynn will address this as well, some of the data that we do have and the direction that we're going. But to date, if you look at prior data, we're looking at generally an overall survival of around 3 months particularly without treatment, less than that. And certain subtypes are more akin, well, any breast cancer subtype could lead to leptomeningeal disease. Certain ones have more of a predisposition. So the two to know are really HER2 positive and triple negative breast cancer. Both of those are more likely to develop metastases to the brain as a whole, or leptomeningeal disease, and the central nervous system as a whole. There are no specific FDA therapies approved specifically for leptomeningeal disease. Now, this has evolved over the years. There are therapies that are approved for breast cancer that have some activity in leptomeningeal disease, but none that are specific for LM. So many of you are familiar with the blood-brain barrier, which of course presents a huge challenge in treating brain metastases. There's also something called the blood CSF barrier. So very similar to the blood-brain barrier, tiny bit of an anatomical difference in terms of, I won't get into necessarily the weeds of this, but a little bit of a difference of what constitutes what makes up that blood-brain barrier and blood CSF barrier. But the idea is the same, which is that therapeutics that generally reach the body don't always reach the brain. So the size of it matters, and how it's made and what it's comprised of matters in terms of how it can potentially cross both the blood-brain barrier as well as the blood CSF barrier. So just kind of a zoomed out bird's eye view, when we're talking about leptomeningeal disease and approach to treatment, there are two goals, right? We want to stop the tumor from forming, ideally kill tumor, but we also want to have quality of life improvement as well. So there are symptomatic goals that we have, which is ideally to reduce the pressure of the brain caused by CSF buildup, reduce pain, reduce any neurologic deficits we have. And then, of course, there's tumor-directed treatment, which is, of course, we want to reduce the number of cancer cells in this space. The way that we achieve that is a few different modalities. So surgery is less of a mainstay in leptomeningeal disease as compared to something like brain parenchyma or metastases in the brain tissue itself. But still, in some situations, it might be appropriate. And surgery might even be appropriate to put a port that directly communicates with that fluid system. So just like we can have ports that go to your bloodstream to deliver chemotherapy to your bloodstream, there are ports that we can place surgically that deliver chemotherapeutics and other therapies directly to that fluid space where cancers are. So surgery might be needed for that reason as well. Radiation therapy is a big part of treatment. Medical therapy, so we talked a little bit about intrathecal therapy or therapy directly into that fluid space, but there are also other drugs like that, like cytotoxic therapies, targeted therapies, et cetera, that can be used. And those can be intravenously administered, they can be orally administered, just depends on the drug. And then palliative care and supportive care is always a part of the conversation. It's not just something that comes up when we are talking about not doing further treatment, right? This is something, to me, palliative care should be woven in through the whole treatment course, because there can be a lot of symptoms, and we want to make sure that we're really addressing all the symptoms and our patients holistically as we're moving through this difficult to treat disease. All right, so we have some of the outlined treatment options. How do we go about making a decision? Well, importantly, and not surprisingly, the type of cancer. So, leptomeningeal disease can happen in many different tumor types. I mentioned we're talking mainly about breast today, but of course, lung, melanoma, hematologic malignancies, really any malignancy that you name. So understanding what cancer it's coming from, solid tumor versus heme malignancy, what that primary histology is, and what those tumor markers are. So what's the biology of that original tumor, and is there anything targetable? Dr. Lin nicely walked you through these targeted therapies as well. So things for example, for HER2 or immunotherapies, some tumor types are going to be more akin to that than others. Making sure that we know the tumor types, the biology, and whether or not the specified therapeutics then get to the location that we need in the central nervous system. Really importantly, the state of systemic cancer. So the first question I ask my trainees after they tell me about what's happening with a certain patient and their metastases is what's going on neck down? What's going on with the rest of this patient's cancer, right? Because we don't want to just look at this in a bubble. This is part of a larger systemic problem of the patient's full cancer. And again, looking at the patient holistically, because a lot of times what we want to do is, of course, try to minimize toxicity. And in order to do that, it's very helpful if we have therapeutics that can kind of kill two birds with one stone. So if we can address the CNS, central nervous system metastases, the leptomeningeal disease, and say progressive lung disease or liver disease simultaneously, we certainly want to try to do that. Importantly, bulky versus non-bulky disease is a key factor. So when we have a very nodular bulky disease, that's not the ideal patient to do intrathecal therapy in, because we can get flow abnormalities in that cerebrospinal fluid. And when we're injecting drug, it might not flow and get to all the places that we need to. if a patient has really bulky disease in their lepto. A patient's performance status and symptom burden is a huge part of it. If a patient has a lot of symptoms and we need to address quality of life urgently, we might opt to race to get to radiation because that can often address in a palliative way symptoms very quickly while still addressing tumor. So these are just some of the factors that come into play. And Dr. Lin really nicely went over this. So I'm going to do these next two slides a little bit fast, which is in general in the past, 10, 15 years ago, it was very normal for us to see CNS metastases excluded. But thankfully, things are changing. We have a lot of new therapies that are targeted. You saw a lot of them in Dr. Lin's talk. We're really kind of the bar is thankfully moving, and we're now increasing this. I made this slide for the first time I think 6 years ago, and it's really I update it every once in a while, and it's always heartening for me to see that we're moving in a positive direction with leptomeningeal disease studies. But generally speaking, another disease that I treat, glioblastoma, has a lot of recruiting clinical trials nationally versus leptomeningeal disease with the much higher incidence has far less. So I would say apples to apples, probably about 15 to 20% of the studies that are actively recruiting in LM versus glioblastoma, but we're certainly moving in the right direction. I would say that this has increased at least fivefold over the past 5 years. And to me, I titled this slide Hope because that's what clinical trials represents for me, and hope that hopefully I can pass along to my patients. This is just a sampling of some of those many clinical trials out there, and I will touch on some of them in a moment, and just kind of give you some of the science. I don't think for me the goal is to teach every clinical trial that's available today. This is a dynamic thing. So if we, today is what, October 24th, 2025, that list of clinical trials that are available nationally is going to change every week. It's like a rotating seasonal menu at a restaurant, right? And so depending on the trial, those trials can rotate out, or they can close for safety analysis, they can close for longer analysis. So these are not statues, these are dynamic changes. And so what I would really love for you to get from this is there are studies that exist in leptomeningeal disease. And I think seeing the right oncologists in those spaces can help hopefully serve as a conduit to those, because to Dr. Lin's point, this is not just a late treatment option. Clinical trials are often some of the best options early on, because I very much see lepto as a chess match. And so we want to make sure that we have as many pieces on our board to play with in terms of our weapons in your arsenal, or doors to open, whatever analogy you like the most. We want to make sure we have as many options as possible when we're talking about treatment for our lepto patients. And so sometimes clinical trials are an early option because that door happens to be open and that door might close later. So it's a dynamic conversation that you should have with your doctor, and you can also reach out to Helene if you're looking for certain folks around the country who you want to see for these diseases. I think here I pass it to Dr. Lin.
Yep.
Yeah.
So one of the things that I did setting the stage was to show what are the treatments that we give in general for patients with metastatic breast cancer. And I want to dive deeper now that you've heard a bit about leptomeningeal disease. What are some of those treatments? What's the subset of those treatments that could have activity in the brain and in the spinal fluid? So again, most drugs don't cross the normal blood-brain barrier, but many of them can still work in the brain. And I sort of think of this as the proof is in the pudding. So rather than assuming drugs won't work, let's assume that they could work, and then let's look at the data and understand from patient experiences what we're seeing. So for patients who have HER2 positive breast cancer, that's where we, I think, have the most data, the most convincing data, that systemic treatments can be effective for patients who have either brain metastases or leptomeningeal disease. So I'm showing on the left in the pink box are the regimens that are designated by what's called the NCCN. This is an organization that puts together treatment guidelines for breast cancer and other cancers. And you can see there are quite a number of regimens, including trastuzumab deruxtecan or Enhertu, the tucatinib trastuzumab capecitabine combo, TDM1 with neratinib, and others that have activity in patients with brain metastases. And then if we look specifically at leptomeningeal disease, we see that there are data. This is not from the NCCN guidelines on the right, but it's just from I'll show you some of the data that supports this box. But we do see data we do see evidence of activity for trastuzumab deruxtecan or the 3-drug combination with tucatinib for the use of trastuzumab directly into the spinal fluid through that Omayo catheter method that you saw Dr. Kumtekar talk about, and then the combination of neratinib and capecitabine. And there are a lot of very interesting drugs in clinical trials, including oral pills that penetrate the blood-brain barrier many more times better than even tucatinib. And so some of them that are in trials are ZN-1041, a drug from Iambic called IM-1363. And importantly, this trial includes patients with leptomeningeal disease. And there are other companies, including Cogent and others, that are also developing drugs in this space. And then some of the antibody drug conjugates that target HER2 also allow patients with disease in the brain to enter. So this is just an example of a trial that was specific to patients with leptomeningeal disease, looking at the 3-drug combination, including tucatinib. On the left, I'm showing all the green boxes are for each patient. Did their symptoms improve, stabilize, or worsen? And you can see there's a lot of green and yellow, indicating that many patients did experience improvement in their symptoms as well as their neurological exam. And on the right is showing patient-rated quality of life scores and patient-rated symptom scores. And what you can see is that you actually are seeing pretty substantial improvements in quality of life and symptom scores as rated by patients with this regimen. So I think that's really important, sort of hopeful that the treatments that we give can in fact make a difference. This is data for trastuzumab deruxtecan or Enhertu in patients with HER2-positive leptomeningeal disease. Each row or each bar represents one patient, and it's essentially how long was the patient able to stay on the treatment without the leptomeningeal disease worsening, with it being controlled. On the bottom, the x-axis is the days. And what's really striking here is, you saw the survival data in patients kind of treated with kind of our older therapies with leptomeningeal disease. And you can see there are a number of patients who are well beyond a year, going into 2 years on this treatment for leptomeningeal disease. So we were very impressed by these data. There's a group in Japan that showed very similar data, and we do use this in our patients. Dr. Kumtekar actually led the U.S. trial of looking at the use of trastuzumab or Herceptin directly into the spinal fluid via this Omayo catheter. The schedule of the U.S. study is shown here, and there was a French study that looked at a slightly different schedule of administration. And both studies actually reported longer survival compared to what we would expect from historical data. So we are also using this in clinical practice in our patients with HER2-positive leptomeningeal disease. If we move to patients with estrogen receptor positive brain metastases or leptomeningeal disease, there are things that we can try. So we do use chemotherapy. We might use trastuzumab deruxtecan. There are hormonal therapies that could be used. The various targeted therapies for patients who have kind of more unusual alterations like HER2 mutations or inherited BRCA1 or 2 or PALB2 mutation. But I will say that the amount of data that we have is much more limited. It's based on sometimes just a couple of patients treated, where a doctor might write in the experience in an anonymous fashion about their patient that they treated. And so we just don't have as much high-level data. And so for this reason, for patients who have estrogen receptor positive leptomeningeal disease, we are often more heavily relying on our local therapy colleagues, including our radiation oncology colleagues, because in general, the radiation type approaches are more reliable. And then same thing for patients with triple negative breast cancer. Again, we have a variety of chemotherapies and antibody drug conjugates and target therapies that we can think about. But again, we more heavily rely on the radiation therapy piece of things especially if a patient's systemic or extracranial or disease outside of the brain is controlled, then we might more lean towards the local therapy and leave the systemic treatment alone. But I will say that for both patients with estrogen receptor positive and triple negative breast cancer, I think the good news is that we are seeing more clinical trials in this space, like interesting clinical trials. Um, One of the trials that you saw earlier was a trial looking at a really interesting concept that's open at Memorial Sloan Kettering, trying to take away iron in the spinal fluid as a growth factor for cancers. There are trials of the antibody drug conjugates that are including patients with leptomeningeal disease. There are PARP inhibitors that are purposely designed to get into the brain. And so I think the hopeful thing here is that drug companies are listening and they are trying to develop drugs that are really tuned to the properties of getting into the brain and to the spinal fluid. So I'm going to turn back to Dr. Gupta.
Hi, guys. And I will say this, the next about 5, 6 slides that I have are with regards to some therapies that are more novel and some trials that are available. I don't want to necessarily get into the weeds of them, so I'm going to go over those a little bit quickly and then kind of wrap things up because I definitely want to make sure that we have time for questions. One question that I get a lot from my patients is proton versus photon treatment. I have 3 slides on this, but I'm going to summarize this in a little bit more of a succinct manner. So protons are a heavier particle than photons, and so they have less of an anterior spread. So when you're looking at this picture here, this is photons on the left and protons on the right. So when you don't have that spread anteriorly, so in front, you're going to spare when you're radiating the spine, you're going to spare things like your esophagus and esophagitis, other stomach issues, and you're also going to spare your vertebrae, which actually make a lot of your blood cells, so your white blood cells, your red blood cells, platelets, etc. So because of that, we know, particularly from studies in another disease type called medulloblastoma, which is typically a childhood cancer, we see that there's less toxicity. Patients definitely tolerate this better. We see less of a blood count drop, which is really important, particularly if we are juggling treating a patient's systemic disease. So let's say metastases in other parts of the body at the same time, because we need to make sure we keep these counts healthy and robust so that patients can get the treatments that they need to for disease even outside of the central nervous system. So there was, I'm going to do this part quickly. There was a study done at Memorial Sloan Kettering that looked at photons versus protons. And long story short, this is some thick science and graphs, but I'm just going to show you. The red here are patients who got protons, and the blue are patients who got photons. And what they saw was that patients took longer to progress and patients lived longer. And there's a larger study ongoing right now that's comparing this in a larger fashion so that we can get better scientific data on this. But this was certainly very hopeful and very exciting preliminarily. Rhenium obisbemeda is another clinical trial ongoing. I'll say that it's a very interesting drug that's given intrathecally. It's a radionucleotide. And where we're at with it now is that it was tested in a phase 1 study looking at escalating doses or gradually increasing doses. They found the dose that probably works best, and it's currently in a clinical trial looking at repeated doses, so giving it more than once to our patients. So that's the study that's currently open. And lastly, I just want to talk about immunotherapy in this setting as well. Again, this slide and the next one are a little bit busy, but I just want to talk about the fact that this study is existing. It's an immunotherapy dendritic cell, essentially vaccine therapy, ran by Dr. Forsyth from Moffitt, looking to take your own cells, power them up, and inject them back into our patients to then fight cancer. And when they're injected back right into that Ommaya space, right into that intrathecal space in the CSF, like we discussed before. So this is an ongoing study that's going on in Moffitt, and then the phase 2 study is planned to open as well in a few different centers, so Moffitt, Duke, as well as Northwestern. So we're really looking forward to this study specifically for breast cancer patients, because the data that we've seen so far from Dr. Forsyth has been really interesting and again, hopeful. I do want to take just a couple minutes and we'll get to questions, but it can be really confusing, I know, for my patients with leptomeningeal disease to kind of understand how everything fits. And the short answer is that things can be slightly nuancedly different institution to institution, but ultimately, this is a multi-center and multidisciplinary care approach with you at the smack dab center at that. What I tell my patients is that their primary oncologist, or in this case, breast oncologist, so someone like Dr. Lynn, that's the quarterback of this. And while all of the, to continue with the football analogy, all of those um, roles are important, from defense to running back to everything. Everyone is important, but that you have a central person making your decisions. And in this case, it would be your breast oncologist in most centers. And that there are many other services, even more than those that I have included here, that are a part of that care and a part of that conversation. And it's really a team approach. It's team you at the center of that. So when you're thinking of that, what to expect, with leptomeningeal disease, you can expect very close follow-up. I tell my patients, I'm going to watch you like a hawk, right? The MRI brains, MRI spines, I didn't write that in here, with clinic visits after each one so that you can review that with your doctors. You can make a plan, even if that plan is, let's keep the same plan, right? Statistically, brain mets, CNS mets, leptomeningeal disease tend to recur. So again, hopefully I'm wrong about that. I always tell my patients there are moments, thankfully, that, it doesn't happen for a very long time, but we just always, it's my job to be prepared for that next step. And I think it's your oncologist's job, your care team's job to be ready for that. So we're going to watch you closely, always have a plan for what's next. And decisions are to be made with your full care team, with one person who's, again, quarterbacking your care, typically your primary oncologist. So I always get, hey, Dr. K, what other questions are we forgetting to ask? I would say, confirm who you're going to communicate with what. If you have a lot of doctors, especially, that can be confusing. Determine the best mode of communication. That's different institution to institution. It could be my chart, it could be phone calls, whatever it is, because that brain mets or CNS mets machinery works different institution to institution. So you want to make sure that you set the expectation and they set the expectation of how you're going to communicate, who you're going to communicate what to and when. So that can very much, having that conversation can not only help you, but also help your physicians understand who's going to be in charge of what in your care. I will say as a whole, I know we talked a lot about a lot of confusing science and numbers, but I think that, all of this gives me hope, and all the hard work that Helene has done to really bring this disease to light and make sure that it gets the attention it deserves. We have more clinical trials in LMD than we've ever had before, and our biologic understanding has tremendously evolved, and we're really trying to learn from our mistakes, move the needle, and move things forward. So with that, I'm going to pause for any questions that we might have.
Thank you both so much. This was really, really helpful. Such good explanations. I'll try to get to as many questions as possible. We have about 11 minutes left, so we'll see what we can get in there. I wanted to address first the question to Dr. Lynn about the I can't say these IBS, but
Yeah.
triplet. How many people are being tested for the P1K3CA mutation when first diagnosed with metastatic breast cancer?
Yeah, we are trying to routinely test people actually with genomic testing from the get-go. I think it just is so useful to help determine not only the existing at that time, but future treatment options. We often will do this with a so-called liquid biopsy or blood biopsy because that test comes back typically in 2 weeks, whereas going through a regular biopsy, asking for an old biopsy and getting that off to a company to get tested often takes longer. So we are routinely doing this actually in our patients.
Thank you. We didn't get into diagnosis today, and I think we're going to at some point have to have a webinar about that to really get into diagnosing LM. But Dr. Kumtaker, can you just say briefly about MRIs and screening? Can you screen before symptoms occur, and what it looks like on the brain and spine MRI so
Yeah.
people understand the enhancement?
Yeah, and I'll just back up and say there are three ways there's three kind of modalities in the diagnostics of leptomeningeal disease. The first is MRI brain and spine, where we can see some contrast enhancement. And if we put the pictures back up from my slides, you can see kind of, it's very linear. It doesn't look like how it looks like if you have a nodular lung or liver met or even brain metastases that's more kind of 3D measurable. Often it's very linear. It can be nodule, but still really hard to measure. The second is clinical symptoms. We talked about a lot about those clinical symptoms, that those raise red flags for us as physicians when we hear them to start that workup. And then the last one is actually the gold standard. Because this is a disease of the cerebrospinal fluid, the standard of care diagnostic tool is currently CSF cytology, which is essentially getting CSF and looking under a microscope to see if they're cancer cells. Now, you are right, Helene, we need a whole hour to talk about the diagnostics in this space. It's something that I've become really passionate about because I think we need to do better here if we're going to do better in our clinical trials. And the good news is we are doing better. So we've learned to use a lot of the tools that we're using in the blood. We're learning. The CSF is a very finicky fluid, so we've had to change the test a little to make things work in the fluid. So to do things like getting genetic material and sequencing in the spinal fluid. So that's things like you might have heard of cell-free DNA or ctDNA, looking at whole cells, even capturing tumor cell enumeration, so counting the cells that we have, cancer cells in that fluid. So there's a few different ways that we're doing it. We're already integrated this into most of our clinical trials in leptomeningeal disease. And Dr. Lin alluded earlier to the NCCN guidelines. We've actually included them in the NCCN guidelines now for leptomeningeal disease as of a year ago. So that was a huge improvement. And so when we have things like that, we're able to get those tests for our patients approved on insurance and things like that. So we're able to do those testing, but that's very much where we in the field feel that the direction is moving for diagnostics more in those advanced CSF. Sorry, that's a larger answer than you bargained for.
No, it's a great answer. And like we said, we're going to do another webinar on this because I think it's really important for people to understand what to ask for and how to advocate for themselves for it. And then also to educate the oncologists who may not be aware that this exists. So we'll definitely work on that. Another question just came in that just follows that. So I want to just address it quickly. But do you see CSF ctDNA replacing or augmenting cytology?
Go
Go
ahead.
ahead.
Yeah.
Yeah, I mean, I think of it as kind of complementing. So I think, so what is ctDNA? It's like little fragments of DNA from the tumor, and we can pick them up in the blood and we can pick them up in the spinal fluid. I think one of the cautions is that we've seen that even for patients with brain metastases without leptomeningeal disease, you can see ctDNA in the spinal fluid. And so seeing ctDNA in the spinal fluid does not equal diagnosis of leptomeningeal disease. And that's super critical because even as trials are getting better, there's still a lot of exclusions for patients with leptomeningeal disease. We do not want to label somebody as having leptomeningeal disease if we don't really believe they have a full clinical syndrome. Having said that, if somebody has leptomeningeal disease, we have seen that sometimes the changes that we can see in the spinal fluid on the ctDNA testing are different than what we can see in the blood. And occasionally we can find something that actually leads us to be able to give a targeted therapy. So I think it's not something that's super widely available right now. It is becoming more available. We actually have been working with a number of commercial companies to see if they could get them online, more the companies that oncologists across the country are more used to using as opposed to small niche companies. There are companies that do this right now. So yes, I think of it as a complement, but important not to overinterpret it because we don't want to declare somebody as having leptomeningeal disease just on that basis.
Yeah, absolutely. Thank you for that. I'm going to stick with you, Dr. Lin, for just a minute. Do you think the in second line and beyond monotherapy is really going to be efficacious? The person who asked says, "I know we're waiting for combo trial data."
Yes, I'm assuming that the person who's asking is asking in the hormone receptor positive or estrogen positive breast cancer patients, where we have now several approvals, elacestrant and imlunestrant, of just the hormone on its own. What's interesting about these treatments is elacestrant, for example, crosses the blood-brain barrier very well. So there is an ongoing brain mets trial with elacestrant and abemaciclib because of that observation. Um, I think the patient is absolutely right, which is that I do think that ultimately we're going to be using combinations. But there are some patients where the monotherapy or the treatment on its own does work very well. So patients who have been on their first treatment for a long time, who have relatively slow growing disease, who have the correct mutation, which is mutation in the estrogen receptor, we do sometimes see really amazingly long responses. It's just that unfortunately, what we also see is that about a third of patients on their first scan, the cancer looks worse. So we have to pick the right patient. We have to pick the patient where knowing that it's still okay to try that treatment. And so
Mm.
that's a selected population.
Yeah, thank you for that. Um, Dr. Kumtaker, back to you for this, or either one actually, but what does stable leptomeningeal enhancement on an MRI mean? And with that stability, do you get function back?
I'm happy to take that. So stability means that the contrast enhancement, so the gadolinium dye that's given intravenously and that's picked up on the pictures, then stable enhancement means the same gadolinium dye is picked up before and after. So things are staying stable. And when it comes to symptomatic improvement, it's a little bit more of a complex issue. I have seen patients improve symptomatically even when the scan looks the same. What I tell my patients is not to necessarily expect it. What we're really trying to do, the probably the treatment that I see the most improvement in is radiation in terms of symptomatic improvement. Although some of these great new therapies that Dr. Lin mentioned as well, when we see disease response there, we often see patients responding symptomatically too. So that's really heartening. Um, I may have gone awry with the question here, but the short answer is it doesn't necessarily mean one thing or the other symptomatically. Those are sort of decoupled in my head.
Okay, that makes sense. We also have a question about what is considered early stage LMD. Um, Due to MRI and symptoms, have not had this checked in spinal fluid, but if spinal fluid doesn't show LMD, what does that mean for the diagnosis?
So there's no medical definition of early stage LMD. So it doesn't mean that it doesn't exist, but we don't have that defined scientifically. So right now it's a binary clinical decision, clinical radiographic cytologic decision where we say in a binary fashion whether or not our patient has lepto.
That's what I thought your answer would be, but I just wanted to confirm. I think that's going to be all the questions for today. I just want to make sure we got to as many as possible. We had a bunch sent in through registration, so I wanted to get to those as well. But this was really great. I thank you both so much for your time. I truly hope this was helpful for everybody that is here and that you're leaving today more informed. Before we go, I want to give you a little incentive to sign up for our newsletter on our website, lmcancer.org, if you haven't already. We will be sending out registration info for our next webinar on caregiving with Dr. Allison Applebaum. It should be a really interesting webinar as well. And a certain number of the early registrations who attend the webinar will be getting a free copy of Dr. Applebaum's excellent book called Stand By Me. So stay tuned for all those details. They will be in the next newsletter, as I said. And finally, I want to say thank you again to our incredible doctors, our amazing producer, and to all of you, our audience members. So I hope everyone has a lovely weekend and we will see you soon. Thank you.